Good afternoon. Thank you, everybody, for joining to our last action period call for the Asthma QI program. I've said this before, but I'll keep saying it. Appreciate all of you for your engagement and hard work throughout this process. Thank you to our program partner, the Ohio Department of Health, and their disclaimer on today's presenters. And I want to welcome you, and then we will go through kind of the usual cadence. So data review with Zainab, and then we'll be hearing from Dr. Stukas on the intersection of allergies and asthma. So Zainab, I have your slides.
Thanks, Brooke. So I want to thank everybody for submitting their data. I know that it could take some time sometimes to make sure that all the data is submitted. So I want to, really thank the practices for taking the time to put that in. I know that some practices may not have all their data in yet, and I know that we're still collecting data for May. So I'm really hoping that everyone can, get through this final push and kind of put everything in, get everything submitted so that we can have the data presented to you. All the data that we're presenting today is aggregate level data. The practices received or will receive their individual practice level data by the end of this week, hopefully, as I get through that. But Brooke, I'm ready for the first slide. So we are collecting data on a couple of things. And so optimal asthma care really is the first one. And optimal asthma care really consists of whether or not they have an asthma action plan in place and a combination of any other two of the metrics that we're collecting. So severity of their symptoms, whether or not they received other handouts, if they were screened for asthma triggers or environmental triggers. And so since December, we've seen a pretty consistent upward trend. In April, we saw our highest number or our highest percentage of patients receiving optimal asthma care. So hopefully we can see this number continue to increase in May. But overall, the practices are doing excellent. Next slide, please. And so this is asthma symptom control. And so, we're looking at whether they're assessed they received the assessment for asthma symptom control. And we're looking at this in terms of like the patient population in general, and we're also looking at it in terms of the diverse patients. And the diverse patients include people of color, so any race other than white, not non-Hispanic, as well as a socioeconomic component to it. So patients with Medicare as their primary insurance, or Medicaid as their primary insurance. But again, we have seen a consistent upward trend since the beginning of QI in December throughout April. We're again at a 95% here. We're hoping to either keep that number or to see it increase potentially in May. Next slide, please. And so this is the other component that we were talking about in terms of diverse patients. So it's the same metric as the previous slide, but it's only consisting of diverse patients here. Next slide, please. And asthma symptom severity. The individual practices don't receive a slide on assessing for severity, but it is in the aggregate slides. If the practice is interested in getting their individual data for that, that's also available to provide. But here we're just looking at their severity to see if the severity of their symptoms is controlled, to see their quality of life, if it's being affected by severe symptoms. Later on, we want to know if the physician referred them to a specialist, and this also comes into play in terms of whether their symptoms are being controlled, how severe they are. Next slide, please. And this is the asthma action plan, which was part of the optimal asthma care in the first slide. So we understand that that an asthma action plan can be in place prior to their visit. We're really interested in whether it was reviewed, if it was edited, if you went over their asthma action plan with the patient, or if a new one was created if that patient was diagnosed at that visit. Again, this is also considered part of self-management material. So when they have an asthma action plan in place, then they know how to better manage their symptoms. They know what can help them and what can prevent some triggers. Next slide, please. And this is the next one. So asthma triggers and environmental factors. We screen for those to see, to kind of give information to the patient and to the primary caretaker of the patient, um, of what environmental triggers often cause asthma attacks, or are there specific things that that your kid or that their kid is really sensitive to, and so this kind of gives the family more information on what to avoid, what's okay um, for their kids. Next slide, please. And this is self-management materials. So included within this is whether or not they received an asthma action plan. And then it can also include other handouts that you have. Yeah, uh, other handouts like asthma specific handouts that you have that's apart from the asthma action plan are also included here in self-management materials. Next slide, please. Here we're interested in patients that have persistent asthma or patients with persistent asthma, whether or not they're on controller medications. In baseline practices, we're doing pretty good, and we've been seeing consistently at around 95, 96% of patients with persistent asthma being on controller medications. Next slide, please. Um, this this metric is looking at if they're current on their flu vaccine, and again, this can include whether or not they received their vaccine at a pharmacy or at a different doctor's visit. It doesn't necessarily have to be a flu vaccine that you provided or that your practice provided. So that's just something else to keep in mind when you're giving us this number. But again, we're asking whether or not they have the flu vaccine for that season. So that's also important to keep in mind. Next slide, please. Emergency department or urgent care visits, we were really trying to see this number decrease. We were seeing it decrease. We saw a little bit of an uptick in April, but still relatively better than what we saw at baseline. So again, we're hoping to see this number decrease with the resources that you're providing, with the care that you're providing. But again, overall, the practices are doing great. Next slide, please. And finally, we're looking at hospitalizations. We have seen consistently at or below 1%, which is great. Our aim here was to, bring it down to about 1%. So again, the care that you're providing, the resources that you're providing, the handouts, all of that is making a difference. And we're seeing, significant decreases in hospitalizations from baseline throughout QI. I think one more slide, the referrals. So the point of the trainings that we're giving and the point of the resources that we're providing is to increase provider confidence in treating patients with asthma. So if their symptoms are controlled, if you have an asthma action plan in place and everything seems pretty simple and easy, then we want to make sure that there are no unnecessary referrals to a specialist. We understand that in some cases their symptoms are not controlled. So in those situations, then a referral to a specialist is necessary, or is recommended. But again, we are seeing very very minimal referrals to specialists here. So again, we can see that the trainings and the resources that we're providing are increasing provider confidence, hopefully. Uh, but I think this is my last slide, and I can hand it back over to you, Brooke, if no one has any questions. You can either put them in the chat or take yourself off mute and ask them. And if anything else comes up later and you realize that you do have a question, please let us know, email us or anything like that.
Zainab, thank you.
Mhm.
Any questions from the group on the aggregate? Okay, hearing none. As Zainab said, I will get you your data on individual practice level as soon as I can, and then I will attach the aggregate data so you can review that at your leisure. Zainab, thanks.
Thank you.
Dr. Stukas, I will stop sharing and make sure that it is enabled for you to share, and the floor is yours.
Okay, can you hear me?
Good, thanks.
All right, thank you. Let me know if my slides don't advance for whatever reason. Well, thanks for joining, everybody. It's a pleasure to be here. Brooke asked me to talk about something that's very timely for all of us and all of our patients, and that's really the role of how allergies and asthma sort of intersect. So that's what we're going to spend today talking about, and I'm happy to take any questions at the end. None of my disclosures are relevant to what we'll discuss, and I really want to spend time talking about the importance of phenotyping and what that means, clarifying the diagnosis, which is going to absolutely impact care. And then we live in this age of individualized management, whether it's allergic rhinitis or asthma or both. And we're going to talk about that as well. But what I really want to do is it's my goal to give you as much practical information as possible. I know you're all super busy. You're cramming this in over your lunch hour. I'm sure you have things waiting for you on the other end. So I do want to make this as high yield and practical as possible. My goal is to provide information that contradicts something you previously believed to be true, at least once or twice today. So hopefully I achieve that. And then ultimately, we just want to improve the lives of children and their families and make your life as easy as possible. All right, let's get into it. So for those who aren't familiar, the terminology we started to use this a lot more for asthma over the last 10 years or so. And we think about endotyping. Endotyping is really what's going on underneath the surface. What are the immunologic mediators involved? What type of inflammation is there? What's the pathophysiology? Whereas phenotyping is more of like observable characteristics. And with asthma, you've all heard this before. It's really asthmas. Because there really is 12 to 20 different types of asthma, and those distinct types of phenotypes of asthma really impact response to therapy, prognosis, and everything. And why is this important? Because it really does impact what's the diagnosis, what's the management that we're going to propose, and then, when we talk about prevention strategies as well, it's important to think about these concepts. So when we think about asthma and allergic rhinitis and atopic dermatitis and food allergy, last time I was here, I talked about atopic dermatitis and food allergy. A lot of these conditions have some shared characteristics. So everybody with asthma is going to cough and or wheeze at some point. Everybody with atopic dermatitis is going to have inflammation and itching of their skin. But what's going on underneath the surface can be vastly different based upon their phenotype that they have, their pathophysiology, and that can impact everything from management to prognosis as well. When we think about the diagnosis of these allergic conditions, there's risk factors involved. We know that family history of allergies in general is a very strong risk factor for their offspring to develop allergies. If you have that infant that has truly early or severe eczema, that's a big red flag that they're going to develop allergies, or if they're already known to have other comorbid allergic conditions. So when you're diagnosing allergy or asthma, these are important things to take into consideration. But the absence of these risk factors does not mean somebody cannot develop allergies. So we can't rule it out based upon the lack of risk factors, but certainly understanding what those risk factors are can be very helpful when we're trying to diagnose these in the first place. We're all very familiar with the atopic march, but this is extremely relevant to what we're talking about today. So for the most part, infants typically start off as having atopic dermatitis, typically presents in the first 4 to 6 months of life, and is typically resolved by the age of 2, or at least it's significantly improved. They may or may not develop food allergies in that early infancy period as well. Respiratory or inhalant allergies typically don't develop until about 12 months of age for indoor allergens. We typically don't see outdoor seasonal pollen allergies till kids are about 3 or 4 years of age. Now, there can be outliers on the earlier end of the spectrum, but you have to be exposed for a couple of seasons before you can develop those allergies. And then they tend to go on to develop asthma later in childhood as well. So there is this spectrum here of these highly allergic kids just tend to develop these comorbid conditions over time. All right, here's the first pearl. So, for those of you who have nodded off already, wake up for this part. All right, so in your office, if you have that infant that's less than or equal to 6 months of age, and they have truly persistent moderate to severe eczema, not that little spot on their cheek that kind of comes and goes and gets better with over-the-counter hydrocortisone. I'm talking about significant portion of their body surface area. You've prescribed high-potency corticosteroids. You've confirmed that the family is gooping them up with greasy emollients all day, every day. They're avoiding triggers. Those truly severe refractory kids, they are raising their hand saying, please pay attention to me. I am programmed to have a very allergic life. Whether it's food allergies, which we want to prevent by introducing allergens early and keeping them in the diet consistently, whether we keep them on our radar if they start to develop respiratory symptoms, those are the ones that are raising their hand saying, definitely pay attention to me. Now, when we think about inflammation, as an allergist immunologist, I think about Th1 or Th2 inflammation. These are just different types of T helper cells, and the cytokines involved are very different. In general, autoimmune conditions have more of that autoinflammatory Th1 inflammation, whereas allergic conditions are more of a Th2 inflammation. And what that means is there's different mediators involved. So in my specialty, I really worry about interleukins 4, 5, 10, and 13, and eosinophils are the predominant inflammatory mediator, whereas if you have Th1 inflammation, it's going to be more neutrophil dominant. Now, why does this matter? Well, it matters because the therapy that we use for asthma especially can be impacted by this. So when we think about the allergic inflammation, whether it's on the skin, in the upper respiratory tract or lower respiratory tract with asthma, we really think about IgE, the immediate, hypersensitivity antibody involved in allergic reactions, and eosinophils. Interleukins 4 and 13 are what lead to IgE production, whereas interleukin 5 is what leads to eosinophil production and recruitment. Take a mental image of this. We're going to come back to this because when we talk about biologics, understanding these concepts are crucial. Because if we use the wrong biologic for the wrong patient and we target the wrong mediator, they're not going to get any better from it. So this really is phenotyping at its essence. So let's create a good fundamental understanding of what asthma is. So we all know asthma is chronic. There's inflammation in the lower airways. The airways are very twitchy and hyperresponsive. It's reversible airflow obstruction. It's not fixed obstruction, and the symptoms are going to be recurrent over time. It's almost impossible to diagnose asthma after one episode of persistent cough and or wheeze. We may predict who can develop asthma, as we'll talk about, but you really have to have recurrent episodes over time. As far as the airflow limitation, we all know this. There's four main reasons for it. You have constriction of the smooth muscles around the airways. You get the airway hyperresponsiveness. You get the swelling inside from the inflammation and edema. And then the goblet cells undergo hyperplasia. So the mucus that patients with asthma produce is very sticky and tar-like. So if you have a swollen airway filled with sticky tar-like mucus and you have constriction of the muscles, it can be really hard to breathe whenever that occurs. So some initial thoughts when it comes to asthma. This is a clinical diagnosis. Yes, all of the guidelines recommend using spirometry to help establish the diagnosis and follow it over time when kids are typically about 5 or older, but that alone does not diagnose asthma. There is no single test that says yes or no, you have asthma. So we really have to use the clinical history to diagnose that. If spirometry shows reversible obstruction, that would support a diagnosis of asthma, but there are other reasons why you can have that as well. We know it's often underdiagnosed. All of you have been involved in quality improvement for asthma for a long, long time. So you're working on ways to better assess it and then monitor control over time. It's expected to change throughout time and over the year. Therefore, our treatment should change as well. We're all familiar with the stepwise approach to asthma. Well, stairs work both ways. Sometimes you climb up the stairs, but other times you climb down the stairs. So we want to step down therapy when kids are well controlled. There are multiple different treatment options available, which we'll discuss a little bit here. And as I mentioned before, we really live in the age of personalized care. In regards to the different types of asthma, we're all familiar with this. There's no one size fits all approach. Do they have intermittent asthma? Is it more chronic based upon the frequency of symptoms? What's their severity? Is it mild, moderate, severe? How frequently are they having symptoms? What age do they present? They can present early in infancy. It can present when they're toddlers, school age, adolescence, and beyond. And all of this really changes the way that we approach treatment and monitoring over time. For those of you who aren't familiar with the Asthma Predictive Index, this is something I use every single day. It's just ingrained in how I assess these children. So what this is this is a predictive model where to enter into it, you have a child who's younger, so they're a toddler, 3 years of age or younger, and they've had 4 separate wheezing and or persistent coughing episodes in the past year. So as you see, the major criteria do they have a parent with asthma? Do they themselves have a diagnosis of atopic dermatitis, or do they have sensitization to aero allergens on skin prick or serum testing? With minor criteria being, do they also have food allergies? Do they have peripheral eosinophilia? And do they wheeze outside of colds? And the way that this is used is it's both a prognostic and diagnostic tool. So if you meet one major or 2 minor criteria, there's an 80% chance that you're going to have persistent asthma at 7 years of age. Whereas if you don't meet any of these criteria, it's unlikely you have asthma. So there's 40% of toddlers will wheeze at some point, but only 30% of that 40% go on to develop asthma. This is a way of predicting who had that lower respiratory tract illness versus who's actually going to develop asthma. And when you look at this, this is just phenotyping at its core, right? So we're finding those allergic individuals or those with risk factors for allergies and things like that. Just to note, nobody is recommending that we do CBCs on patients to diagnose asthma. If you happen to have evidence of peripheral eosinophilia, that's when you would, apply it here for the predictive index. All right, here's the second pearl. If you have a child less than or equal to 4 years of age, and every time that they get an upper respiratory infection, their parents tell you that they cough for 10 to 14 days, that is asthma till proven otherwise. And I know there's other diagnoses out there like, bronchitis and, things like that. But if this is really happening every single time they get sick, I would strongly encourage you to have the conversation about asthma and think about inhaled medications for them as a diagnostic and therapeutic trial. So when you see patients with asthma, I would encourage you to start thinking about what type of asthma do they have. For Th1 inflammation, which can occur with asthma, that's typically going to be more later onset or adult onset asthma. A lot of folks who smoke cigarettes or tobacco products, they're going to have more neutrophil dominant asthma, and they're going to typically have a history that lacks allergic sensitization or allergic comorbidities. Whereas if you have the Th2 inflammation, which is most of our patients, so 75% of children with asthma have comorbid allergic rhinitis or sensitization or allergens. So these are the Th2 kids. They have the other allergic comorbidities. They often have lots of eosinophils. And then if you do exhaled nitric oxide testing, you'll find that it's elevated in many of these children as well. So that's how we sort of phenotype. And why does that matter? I'm not going to go through all this. There's great references and resources. But if you have that Th2 asthma, you're generally going to get a lot better when you use like inhaled corticosteroids or when you target the Th2 mediators like IL-3, IL-14, I'm sorry, IL-4, IL-13, IL-5, because this is going to be more eosinophil driven. But if you have Th1 asthma, it's not going to help them to put them on a ton of steroids. That's not what's going to make them better. So this is when we want to talk about using other therapies like long-acting bronchodilators, antimuscarinic agents, and things along those lines. So again, the vast majority of our patients are going to be that Th2 asthma. So we don't have to worry about that so much. In regards to management, you're all very familiar. We have the intermittent and persistent. So intermittent, it's really recognizing when symptoms are progressing and as needed therapy. Whereas if they require a daily controller, we also want to make sure that we assess their environment. I've had so many patients over the years where it doesn't matter what medication I give them because they go home to a house filled with passive tobacco smoke, indoor allergens that they're allergic to, poor air quality, things like that. And then everybody with asthma absolutely requires good education about what this condition entails, self-management skills, teaching on how proper use of their inhalers, otherwise they're not going to get medication delivered to the lungs where we want it to go. What's the follow-up plan? It really shouldn't be set it and forget it. It should be, when should we see you back, whether it's 3 months, 4 months, 6 months, a treatment plan that can be shared with school or daycare, and then just support for all of their needs. Because as we all know, these families have a lot going on, and especially if they're in and out of the emergency room or hospital because of their child's asthma. I love this graphic. This is from the GINA asthma guidelines. So if you're not familiar, these are the global initiative for asthma guidelines that are updated every year, as opposed to the United States NHLBI guidelines, which are updated every 50 years. The last iteration was 2020. But GINA is nice. And I love this graphic because this encompasses, this is what asthma management is in 2024. If we're not taking the same approach for every patient, then we're really doing a disservice. So we want to continually assess, did you respond to therapy? If you didn't respond to therapy, do we need to adjust things? If you did respond to therapy, are we able to step things down? And we want to review symptoms. What's their course? And this really is setting the stage for families of, listen, your child's very young. Their asthma is going to change throughout the year. It's going to change over time. There are periods of the year where we need to step up their therapy. Other periods of the year, like summertime, we can often step things down when they're doing well. And what we do in regards to management next year may not be the same as what we do this year, and so on and so forth. So just sort of establishing that mentality of families at the time of diagnosis can be very helpful. That way, hopefully they're more prone to call you when their child's having issues and not just think that there's no hope or no options available and they have to go to urgent care or the emergency room. So what are our goals of asthma therapy? We want to reduce chronic symptoms, ideally prevent exacerbations if we can. We want them to exercise. I hope I don't have to educate anybody here about the benefits of exercise for people with asthma. We want to keep them out of the healthcare system as much as possible for acute management. And we do want to monitor for adverse effects. It's important also to recognize that people with asthma, you're not going to cure them. You're not going to completely eliminate their symptoms, but you want to minimize the burden. So it is a false expectation for somebody never to have symptoms if they have asthma. We want to make these as infrequent and mild as possible, but it's going to happen. All right, so in regards to relievers and controllers, now is where we're starting to see some overlap with smart therapy and things like that. So relievers, obviously, they work fast. We want them to have them available at all times in case they have acute symptoms, whereas the controllers are more for long-term management. In regards to the inhalers, we're all struggling with this at the same time. So we're having medications that are being discontinued, such as brand name Flovent. We're having shortage issues, such as generic fluticasone and Asmanex. Insurance companies are changing their formularies. It seems like every 6 months. So what a patient of ours was on right now, and they're well controlled, it may just be changed and it's completely out of our hands. So when we get that message from the pharmacy that it's been denied, we have to recognize that there are different types of inhalers that may go along with whatever's covered. And some of these may not be suitable for our younger patients. So for dry powdered inhalers, if we don't practice the right technique with them, they're never going to be able to do it, especially if they're younger. Some of the package inserts say that you can use dry powdered inhalers, down to the age of 5 or 4. I will disagree with that because you really have to generate a high inspiratory flow rate and then hold your breath, ideally for 10 seconds to let the medication settle. That's really hard to do for younger children. So that's where we have to do prior authorizations and basically say, our patient is too young to do this. Can we get something else covered? Whereas if you have the HFA or meter dose inhalers, that can be done by anybody, regardless of the technique. So just being mindful about, what type of inhaler is being prescribed or covered by insurance companies, making sure we can practice with each family. Ideally, having a respiratory therapist go over this with them or at a pharmacist at the time of when they dispense the medication. But this is just an ongoing battle, and I don't see it getting better anytime soon, unfortunately. Now, we can bronchodilate multiple different ways. So we're all familiar with albuterol as a short-acting bronchodilator. We also have long-acting bronchodilators, such as formoterol and salmeterol. Anticholinergics may be beneficial. There's a proportion of children with asthma that just don't respond well to albuterol. You can get tachyphylaxis if you're using it too much over time. So we don't have to just use anticholinergics in the emergency room or inpatient setting. This can be an appropriate therapy for outpatient as well, especially if they're not responding well to albuterol and we're convinced that's what their diagnosis is. And then we have long-acting antimuscarinics as well, which were included for the first time in the 2020 NHLBI asthma guidelines. So we have multiple different options, and it's really entails being thoughtful about what are we treating, how are we demonstrating, what type of asthma this patient has. I think about bronchodilating. So if you have somebody that doesn't have a lot of inflammation, so if you have a normal exhaled nitric oxide, but their FEV1 is very low, 60%, and they have a huge response, maybe we should, instead of treating them with more and more inhaled steroids, let's try to bronchodilate and let's try to improve their lung function over time and see them back in a relatively short period and see if they're actually getting better or not. Now, before we go any further, this is the other wake up moment if you're willing. So let's talk about albuterol for a second. So I strongly discourage anybody from referring to albuterol as an emergency inhaler. If we tell families that this is for an emergency inhaler, that tells them a couple of things. One, they need to wait until it's emergency to use it. Number two, if they use it, they feel like they need to go to the emergency room, and it really does delay administration. Instead, I would encourage you to use words like reliever or rescue inhaler, and we want them to use it sooner rather than later. So just being mindful of the terminology and the words that we use. And in regards to how much albuterol, I always include this because this goes back, oh my gosh, almost 20 years now in the United States guidelines. 2 puffs every 4 hours for albuterol is not going to treat most people having an acute asthma exacerbation. And if you look at guideline-based care, we're talking about 2 to 6 puffs every 3 to 4 hours for the first couple of days. Or if you look at the GINA guidelines from 6 years ago, 4 to 10 puffs every 20 minutes for that first hour. So the reason why is because we want to bronchodilate like crazy if they're having acute symptoms, because the longer you wait, the harder it gets to actually dilate those lower airways. Then you get all the inflammation setting in and that mucus we talked about before and things like that. And when we talk about the method of delivery, I don't understand how in this day and age we still don't have folks that understand like MDIs and spacers are superior to nebulizers. So there's been meta-analyses done on these, and including children having mild to moderate exacerbations. There's a Cochrane review from a decade ago with almost 2,000 children that if you use the MDI with the spacer, it's equivalent, if not superior, to the nebulizer, and it has less side effects. So we always want to promote, proper teaching and use. Nebulizers are not very user friendly. We don't want people to have to go home to get their asthma treatment. We want asthma treatment to be portable. Now, oftentimes you have to give 4 puffs of albuterol, sometimes 6 puffs of albuterol to equate to that one nebulized treatment. And that's completely okay, as I just showed you, which is guideline-based therapy. So just things to consider. We want to make this as easy and family-friendly as possible when we're helping families manage their child's asthma. And of course, I also don't understand how we have to argue that we need to use a spacer. So it's not a technique issue. It has nothing to do with age. It's the medicine and the MDIs sit in there as a liquid. We want it to turn into a nice mist to breathe inside the lungs. It takes about 4 inches to do that. You can have the best technique in the world. If you just put it in front of your mouth, most of the liquid absorbs through the tongue and you swallow it and it goes to your stomach as opposed to the lungs. The best argument for why we need to use a spacer, the primary medical treatment for eosinophilic esophagitis or inflammation in the esophagus is to use an inhaled corticosteroid without the spacer because you swallow the steroid and it goes to the esophagus. So I can't think of a better argument than that, and I hope everybody's encouraging spacer use. Of course, if it's a dry powdered inhaler or breath actuated inhaler, you can't use the spacer with it. So just being mindful of what type of inhaler they get prescribed and how to use it. Now, albuterol is safe. So when you look at the serious side effects, yes, it can cause jitteriness by activation of those peripheral receptors, and it can increase your heart rate temporarily. But any of these serious adverse effects almost always occur with ongoing, continuous, high dose nebulized albuterol, which is typically in the intensive care unit or in the emergency room setting. So we want to promote this, with our families when we're prescribing albuterol. It's going to relieve your symptoms. We want to, open up the airways and relieve and make them feel better as soon as possible. All right, so the current management strategies with albuterol are actually starting to go a bit by the wayside. If you look at the GINA guidelines, there's very few indications just to prescribe albuterol by itself. So GINA actually now says use inhaled corticosteroids and formoterol. In the 2020 NHLBI guidelines, it's still not quite there yet. There is provisions to use, albuterol along with inhaled corticosteroids, either on demand or just, one or the other. But with smart therapy, now this is as user-friendly as it gets. So I'm going to put brand names because there's no alternatives here. So there's Symbicort and Dulera because they contain formoterol. This is the most important part of this. So if you have an inhaled corticosteroid combined with long-acting beta agonist, but it's like Advair, which has salmeterol, you can't use it for smart therapy. And the reason why is because the onset of action for formoterol is the same as albuterol. So you bronchodilate very quickly, you feel it, and then it stays bronchodilated for 10 to 12 hours. Salmeterol takes 1 to 2 hours before it bronchodilates. So that is not an effective way to use smart therapy. We don't know about some of the other newer long-acting beta agonists like vilanterol and stuff like that. So as of right now, guideline based, you have to use the formoterol. And the idea with this, you can use it a couple of ways. So one, actually, I encourage anybody who hasn't read them, look at the GINA guidelines. There's a great update this year. They just put it online. Also look at the focus updates for the asthma to the NHLBI because they have extensive discussion of all of these things. I'm not going to read all of this to you, but this is from the 2020 US guidelines. Basically, it's in young children for moderate to severe persistent asthma. Here's your one controller. Use it twice a day. When you get sick, do it 4 times a day. For individuals, 12 years of age, you can use this as a controller or reliever. So you can just say, here's your inhaler. Use it whenever you want, however much you want. And a lot of people gasp at that and they say, oh my gosh, how can that be? Well, if you think about asthma for most people, they're typically fine 95% of the time. And then they have an exacerbation when they get a viral illness or they're exposed to wildfire smoke or poor air quality or something. So we'd much rather treat the inflammation and bronchodilate at the same time. They're not going to abuse these inhalers. There is always concern about insurance coverage because if they're doing it every day and as reliever therapy, they might go through the inhalers faster. We're seeing a lot more coverage now compared to even last year because of all the advocacy going on from professional organizations and stuff. But all I have to say is that's not a reason not to try it, not to prescribe it. We can cross that bridge when we come to it. Odds are they're not going to use it twice a day, every day, anyways, because most of our patients are non-adherent for whatever reason. So we might as well give them something that's going to both treat the inflammation and bronchodilate at the same time. And for those of you who aren't familiar with it, I encourage you to, play around with smart therapy. It's so user-friendly. Patients love it. It's one inhaler. It makes life a lot easier. So here's pearls 3, 4, and 5. Before you increase therapy, we always have to check adherence. The former U.S. Surgeon General C. Everett Koop had a famous quote that said, drugs don't work in people who don't use them. So if they're not taking the medication that was prescribed, it makes no sense to increase their therapy. There's no indication to treat anybody with inhaled corticosteroids at high doses as monotherapy. If they're not getting better on medium dose inhaled corticosteroids, please do not increase them to high dose inhaled corticosteroids without adding on a long acting beta agonist. And in fact, I would argue keep that inhaled corticosteroid dose lower and add on the LAVA. They're going to get better, I promise you. And because we are going to start to increase adverse effects and things like that as you give high dose inhaled steroids, which probably aren't going to help a whole lot anyways. If they're not getting better on medium dose, they're telling you they're not steroid responsive. So we need to bronchodilate and try to treat their asthma other ways. And then lastly, montelukast has never been a primary treatment for asthma or allergic rhinitis. No guideline ever lists it as a #1 treatment. It is listed as an alternative treatment for some people. And for those of you who aren't aware, it has a black box warning for the last 2 years. So anybody who prescribes montelukast has to read the verbiage included on the black box warning, which includes discussion about the rare but potentially severe side effect of montelukast that can cause severe behavioral changes in children who take that medication. It typically occurs in the first 30 days of starting treatment, and it often goes back to baseline once you discontinue it, but it's something all of us have to discuss with families every time we prescribe this. So a whole lot of reasons to reconsider our use of montelukast. All right, let's talk briefly about biologics, then we'll talk about allergic rhinitis and have some time for questions. So this is phenotyping at its finest. So biologics are specific targets of the immune system where they can really, decrease side effects. Corticosteroids are great because they just calm down inflammation, but they're terrible because they're not specific. So they cause tons of side effects. I used to joke with families all the time of like, I can make sure that your child never coughs or wheezes again. I can put them on a high enough dose of prednisone. You won't like me very much because they're going to have stomach ulcers and poor growth and brittle bones and cataracts, but I can fix their asthma. Well, now we can actually fix their asthma without having to worry about those terrible side effects. So when we think about moderate to severe persistent asthma, many of you aren't going to be prescribing biologics in your office, but please be aware of how to recognize those patients that may benefit from it. So if you're doing everything you can, they're not responding well to therapy, it's even one of your outcome measures of referral to a specialist. Those are the ones that I would encourage you to refer for evaluation from a board certified allergist, immunologist, or pulmonologist, and really thinking through, well, how can we target different parts of the immune cascade here. So omalizumab has been around for 20 years. It's indicated down to the age of 6, and you basically just have to have an detectable IgE to any indoor allergen, such as cat, dog, dust mite, or cockroach. We have the 3 anti-IL-5. So as I mentioned before, interleukin-5 is a main mediator for eosinophils, which is a predominant biomarker for kids with allergic asthma and Th2 asthma. We have mepolizumab, benralizumab, reslizumab, indicated down to different ages. Dupilumab is also available. That's more of the IgE as it targets the common anti-IL-4, IL-13 receptor. And this is, you don't have to have a biomarker. It just basically says eosinophilic phenotype, whether you can demonstrate that from your phenotyping or exhaled nitric oxide or peripheral eosinophilia. And then we have tezepelumab, which is more of a structural biologic. You don't need any biomarkers for that. So if you have somebody, if you're not sure if they're Th1, Th2, or you don't have the biomarkers to support filling the other ones, that's where we start thinking about tezepelumab. So we have multiple options to consider. As I mentioned before, if we don't choose the optimal candidate for each of the therapies, then they're not going to get better. And each treatment for these costs thousands of dollars. Now they're highly effective in the right patient, but they're completely ineffective in the wrong patient. So this is where phenotyping really comes into play. All right, let's transition to allergies and asthma. So when we think about environmental allergens, you can be exposed on a chronic basis, or you can have acute exposure that can cause asthma flare-ups and exacerbations as well. So the most common chronic inhalant allergens will be things like cat and dog dander. That's a picture of a dust mite, which we all have. They live inside bedding and pillows and stuffed animals, and then cockroaches and mice are big problems as well, especially in the inner city population. Outdoor pollen and mold spores can be causes of seasonal allergy symptoms. So in most areas, and especially here in Ohio, we have trees that pollinate, typically from March through May. Hopefully this week will be the last week for tree pollen here. We'll see how it goes. Grasses then start to pollinate late May, early June, along with the weeds. We will see ragweed begin in mid-August every year until we get a frost in the autumn. And then mold spores are prevalent whenever it's damp and rainy outside. So for some of our patients, if they're allergic to trees, grasses, and ragweed, then they're miserable from pretty much Valentine's Day through Halloween. But it's important for us to recognize what those patients are allergic to help guide their management. So I always recommend clarifying the diagnosis. Are they exposed to it? So you can have somebody that has a huge skin test or blood test to cat, but they don't have cats inside their home. That's clearly not what's driving their symptoms. I get this all the time. I share a lot of patients with our ENT colleagues, and they keep sending them back because it's like they keep saying, well, it must be due to allergies. And I say, well, no, they have allergies, but that's not what's driving their symptoms. So yes, they have allergies during this period of the year, but their symptoms are year round, and they have severe, sinus problems and anatomic abnormalities and things like that. So what symptoms do they have? And then do we have testing? So we have wonderful testing available to help clarify what's going on with each of these patients. We don't have to guess anymore. So when it comes to all the different forms of rhinitis, there's significant overlap here. So we have infectious rhinitis, and this is where I mentioned before. So those young, those babies and toddlers that have recurrent nasal symptoms, it's very unlikely that they have seasonal allergies until they're 3 or 4 years of age. It's much more likely that they have recurrent viral infections, especially if they go to daycare and things like that. Then we have allergic rhinitis, and then we have non-allergic rhinitis. So every symptom that can occur for these can occur for all the different, causes as well. And then even if it's allergic rhinitis, is it seasonal rhinitis? Is it perennial rhinitis? Or is it mixed where they have allergies to both indoor and outdoor inhalant allergens? And then what are the comorbid conditions that go along with this? As we mentioned before, asthma, terrible conjunctivitis, especially during the spring. You can have atopic dermatitis or food allergy as well. So here are the next 3 pearls. So as I mentioned, all of the symptoms that can occur from allergic rhinitis can occur for non-allergic causes. So we want to clarify the diagnosis. Here's the major overlap that I see. Adenoid hypertrophy is a big one. Inferior turbinate hypertrophy is another major cause of significant nasal congestion as well. So these are the kids that have chronic stuffy nose. They wake up with mucus and they're coughing their heads off when they first wake up. They're mouth breathing and talking, like they're always stuffed up. Oral antihistamines do not treat nasal congestion or postnasal drip. So if that's the predominant symptom, you can give them as much cetirizine as you want. It's not going to fix those symptoms. Oral antihistamines are most effective for itching and sneezing. So if those are the predominant symptoms, we have to treat a different way. And then please don't tell families to get rid of their pets, even if they are allergic to their pet. It's unlikely that they have to get rid of their pet. We have multiple tricks up our sleeve to help them keep the pet inside the home and treat the symptoms. In fact, many of the children with cat and dog allergy may not have symptoms with their own family pet because they're exposed to them on a regular basis and they're kind of desensitized. There's a cool phenomenon called the Thanksgiving effect, where it's children with cat or dog allergy grow up in a house with their cat, their dog, and they're completely fine with their own animal. And they go off to college for the first time. Then they come home for Thanksgiving and they've been away for several months. And then they start to have symptoms around their pet that they were previously desensitized to. So we don't need to get rid of their pets. They'll just find a different doctor, I promise you. All right, next three pearls. So IgE testing identifies sensitization. So just because you have a detectable IgE does not necessarily mean that you are allergic, especially on blood testing. We get tons of false positives. So we always need to correlate that with the symptoms. And that's what's reinforced in the 2020 asthma guidelines as well. If we have negative testing, we don't need to treat with antihistamines. So antihistamines don't treat congestion. I already mentioned that. We want to get rid of first generation antihistamines like diphenhydramine, because they have terrible side effects and they're very ineffective at treating nasal symptoms in the first place. And we don't want to tell people to rip up carpeting and buy expensive dust mite covers if they're not actually allergic to dust mites in the first place. And then for all of you, absolutely, you can do a clinical and therapeutic trial. So if their story, sounds significant for seasonal allergies, and you put them on a daily second generation non-sedating antihistamine and their symptoms improve, they probably have seasonal allergies. So you probably don't need to do a whole lot from there. If they don't get better, or if you're questioning the diagnosis, that's when we would reconsider evaluation or think about testing. So, as an allergist, we certainly don't need to see all of your patients. You are all fantastic at what you do. Start with your first line therapies, and then if they're not getting better from there, that's when we're happy to see them. Now, as far as mitigation strategies, well, it starts with what's the diagnosis. So as I mentioned, you can have positive testing, but not be actually allergic to it, or you may have symptoms, but it's completely unrelated to what your testing shows or things like that. Are they actually exposed to the allergen? So, if somebody tests positive for cockroach, but they can't find cockroaches in their home, I'm not going to have them fumigate and things like that. There's no single measure that will help. This was hammered home repeatedly in the last asthma guidelines. We can't just say one measure. So for instance, if we think that somebody has dust mite allergy, we want to talk about dust mite covers for their mattress and pillows. We want to wash all their linens in hot water every week. We want to take all the stuffed animals and extra pillows off their bed, and we don't want to use humidifiers in their room. If they have seasonal allergies, outdoor pollen, we want to keep those windows closed at all times, even on days like today. Leave the pollen outside. Change clothing after coming inside, and then definitely bathe or shower before bed every night to get the pollen off of your hair. If you have cat or dog allergy or animal allergy, you want to keep those animals out of your bedroom. We want to use a HEPA filter on the vacuum several times a week, change those sheets and dust and things like that. So there's no single measure that's really going to help. And then I just want to take a second to say, for any of you who recommend air purifiers for your patients, just a lot of caution. There's no good evidence that shows that air purifiers work a whole lot. They're really good for that corner of the room. So it doesn't do anything for seasonal allergies because the pollen is really small and light and it gets spread everywhere, inside and outside the home. If you have, cat or dog allergy, that dander is relatively heavy, so it might make sense to do an air purifier. But these are super expensive. So for us to recommend somebody spend $500 to $1,000 on something that's going to have very little impact, I think we need to be, cautious about that. This was addressed in the 2020 asthma guidelines, and you see this. There's really no evidence that these interventions make a difference in regards to asthma management. So just something to keep in mind. Okay, when we look at the pillars of treatment, intranasal corticosteroids by far are the #1 most effective therapy for every single symptom that occurs from allergic rhinitis, whether it's itching, sneezing, nasal congestion, postnasal drip, but you have to do them every day, and it takes a couple of weeks before they start to have effects, so we generally want to know what they're allergic to and start it prior to the onset of pollen season, ideally. But if you're going to pick one, that's the one that we should go with. Oral and intranasal antihistamines really can be used as needed. They're best for itchy, sneezy symptoms, and we do want to skip those first generation antihistamines because they're just so outdated, have tons of side effects. And then there's a whole milieu of different eye drops that can be used as needed. If you store the eye drops in the refrigerator, the coolness can help lower some of the burning that occurs from that. And we don't want to use things that have vasoconstrictors in them, whether it's in the eyes or the nose, because they're not really going to treat symptoms, and you can get the rebound effect, such as rhinitis medicamentosa in the nose and things like that. All right, as we wrap up here, so let's talk about long-term management for those patients that have, truly severe, persistent, or refractory allergic rhinitis, despite our best efforts, or who are just sick of taking medication or sick of feeling miserable. We have immunotherapy. So we have subcutaneous immunotherapy through allergy shots, or we have sublingual immunotherapy, which goes under the tongue. This was specifically addressed in the 2020 asthma guidelines. I won't read the whole summary, but basically it says it recommends subcutaneous immunotherapy if there's evidence that their allergies are worsening their asthma. So just because you have allergies and asthma doesn't mean you need allergy shots. Is exposure to your allergen worsening your asthma? Couple quick pearls. One, this is a long-term, not acute treatment option. We generally don't see benefit from allergy shots till at least 6 to 12 months after starting therapy. So our phones ring off the hook every spring. I'm not going to fix you right now with allergy shots. Maybe if we start now, we can help you for next spring, but I can't offer you that through allergy shots right now. And then we have to identify the optimal candidate. So if they have poorly controlled asthma, they're not a good candidate for allergy shots because that puts them at risk of having an allergic reaction every injection that they get. Typically, injections are given by buildup once a week for about 6 months, and then once a month for up to 5 years. So we're not treating people for the rest of their life, but we do want to commit to at least 3 to 5 years of treatment to provide the most long-lasting benefit. And then asthma must be well controlled, as I mentioned. So what's the history? What's the testing? Are they a good candidate? And then we have sublingual immunotherapy. And then in the guidelines from 3 years ago, 4 years ago now, they say that they don't support the use of slits specifically for the treatment of allergic asthma. That's an evidence base that may evolve over time. The concepts are the same. It's just a different delivery of putting drops or tablets under the tongue. As of right now, there's 3 FDA-approved products. There's one for ragweed, one for grass, and one for dust mite. So if you have a patient with severe tree pollen allergy, that's not going to help them a whole lot. Or if the cat and dog allergy, it's not going to be a good treatment. But there are non-FDA-approved approaches. There's a lot of folks even in Ohio that make up their own drops and they prescribe it. It's just caution because these aren't always well regulated, and there's a lot of voodoo that goes into the immunotherapy, both from an allergy shot and sublingual aspect, but there are different approaches that are being used as well. So the top takeaways, and I'm happy to take any questions, would be if you're open and willing, start practicing by phenotyping all of your patients to really think through what type of asthma and, do they have. Is this truly allergic rhinitis? Is it, are there other reasons why they're having these symptoms? We always want to clarify the diagnosis of allergy, especially if you're trying one thing after another. Let's just pause. Let's see, are they actually allergic or not? Because that may impact everything from management to prognosis. And then we have so many options available. So we really don't want to settle for anything less than complete control. Biologics are a game changer for the optimal patient, especially if you have patients that are in and out of the emergency room or hospital. Those are very strong candidates for consideration of that. And I thank you all very much for your attention today. I hope, as I mentioned, I shared something new with you and questioned what you believe to be true about the world that we live in some ways. So happy to take any questions.
I have a question. So, as you know, no one likes to do nasal sprays, especially the young kids. Would you say that if they've tried it or they won't use it, or the parents like it's just not working, I have to hold them down, would you have them do Zyrtec, or is it not even that effective based off your experience? Because this is where I struggle too with that.
Yeah, that's a great question. So there's lots of tricks we can do. I always tell every family, listen, I don't want you arguing over this or fighting every night or holding them down or anything. Like, no, no, no. Practice makes perfect. So let's practice with a saline spray. That's generally well tolerated. Reward systems work really well for little ones. Especially in the moment, we'll give you screen time if you do your spray or sticker charts or things like that. So really thinking through that type of reinforcement. But then I do have a conversation like, listen, I'm not going to waste your time. This is going to be the most effective thing. The anything by mouth isn't going to be good for congestion and postnasal drip. So just explain it to them and just, this is what we have to offer. And then at the end of the day, there's a lot of children that, all right, well, if we don't do anything, this is going to get better by itself anyway. So that's fine too sometimes. If they're truly miserable and they can't sleep and things like that, we have to have a different conversation. But yeah,
Great, thanks.
if you figure
Yeah.
it out, will you let me know?
Yeah, right. I mean, the only thing that I've noticed that some parents will say works is the Sensimist, but it's not
Oh,
covered. So you have to get that over the counter, and like no insurance, at least that I found hasn't covered it.
Yes, thank you. So one important thing to keep in mind, there are a dozen varieties. Some of them burn and sting, some smell bad, some have an alcohol base, some have water base. My personal favorite, I have no stake in the company, is Sensimist. It delivers this fine plume. It's a cousin of fluticasone. And you can find it, the best price I found is at Costco or Sam's Club. You can get, 6 months supply for like $30 or something like that. So thanks for bringing that up. Much better
I
start
have
rate.
I have a question. In terms of the smart therapy, say they're on Symbicort like twice a day and then they have an acute asthma exacerbation, how often can they use the inhaler at that point in time?
They can double it, so you can go up to 4 times a day. So
Okay,
if
so
they're
4 times.
Yeah, if they're already taking it twice a day, and in fact, so if you have a patient that every time they get a virus or a cold that they're going to have coughing or wheezing, go ahead and start it at the onset of the cold. That's what it's there for. So as soon as they get a runny nose, because you're not going to hurt them, go from twice a day to every 4 hours while they're awake, and then do that for a week and see if they respond. And for a lot of folks, that's all it takes to kind of keep them off prednisone.
Okay, thanks.
Now, what we don't know the answer to, and we just had our asthma conference at Nationwide Children's, and this has been the debate for a couple of years of, all right, what do you do like pre-exercise? Or what do you like, are we prescribing albuterol anymore? You're going to get 100 different answers from 100 different people. So you can make an argument, if we're going to treat pre-exercise, why not just bronchodilate and treat the inflammation with one inhaler? There's no good evidence for that, but I mean, that's where, if we extrapolate from other studies, or for a lot of patients, if they're well controlled and they're exposed to a campfire and they start to cough that night, can they use albuterol versus their Symbicort? There's no right or wrong there. So it's just a matter of how easy do you want to make it? How long do you have to have that conversation, that sort of thing. But I just want to be upfront with everybody. There's a lot of unknowns here. But by and large, you're not going to hurt anybody by using the formoterol.
Okay, thanks.
Dr. Marco, do you want to elaborate on your comment?
Oh yeah, it's just generally it's based off of age too, is the total number of puffs. So it roughly comes out to every 4 to 6 hours you can continue using 1 to 2 puffs. But for less than or for greater than or equal to 12, they say 12, and then less than that 8 total puffs is pharmacologically what is in the guidelines recommended.
So you may have seen this come through, but the asthma training series, the last session is moving from June 10th to June 11th, same time at 12:30. I'll be sending out more information on that just for a reminder. So again, new date of June 11th for the third session. And then next steps for the program piece. So asthma program for QI and what we've been working on. So the May data still due Friday, June 14th. Data submission cannot be delayed in June. We're kind of up against some deadlines, so would love your help getting that in by June 14th. And outstanding items, I sent that email a little bit ago. Let's work together to complete those or get things scheduled as soon as you can. And then recorded sessions that we didn't have an extra meeting for. So the lived experience expert panel and then the uneclipsing asthma with Dr. Wells, those are both posted to the asthma program website. So if you have a minute, please review those. Good information is there. And then we are just continuing to collect the monthly patient totals for each month through the end of May. Okay. Any program questions or last minute data questions? Okay, hearing none, I'll give some time back. Thank you so much for joining today, and I will be in touch. Thank you so much. Have a good week.